acumen, surgical expertise, and academic collaboration, all in the tenet and moratorium of when not to operate. So, without coming across as a hindrance to the liberation of academic freedom and not wanting to offend anyone, I have to still impress upon you all certain housekeeping rules to ensure the smooth flow of this lecture that it so deserves. 1, please maintain the physical distancing, which has been sorted out with numbering and alternate spacing of the rows and columns. Number 2, kindly ensure that all mobile phones are off, and messaging, checking phones, and going through the data of social media is kept to a minimum or not, preferably. Lastly, I would advise everyone, once the lecture has started, okay, to stay seated, practice restraint if necessary, and not leave the lecture halls till the lecture is over. All right. During the lecture, just before Professor Adiba, our Dean, and Prof. Dharmendra, the speaker, come in, I will give you all a cue to stand up, to welcome them in, and to remain standing, and we will play the national anthem, followed by the University Malaya song. So please continue to stand in attention. Once that is over, I will give you all the cue to sit down. Okay. So we will just wait for them to come. Okay, if I could request everyone to stand. Okay. We'd like to welcome our Dean, yang berbahagia, Profesor Dato' Dr. Adiba Kamarul Zaman, and the man of the moment, yang berusaha, Professor Dr. Dharmendra Ganesan. Kindly request all of you all to remain standing in attention as we play the national anthem and the University Malaya song.
Maju
Ladies and gentlemen, pray be seated. A very good afternoon to all. Yang berbahagia, Professor Dato Dr. Adiba Kamaruzaman, Dean, Faculty of Medicine, University of Malaya. Yang berusaha, Professor Dr. Dharmendra Ganesan. Distinguished guests, professors, fellow academics, ladies and gentlemen. It is our singular honor today to welcome you all to the inaugural lecture by our esteemed colleague, Professor Dr. Dharmendra Ganesan, themed Conservative Spinal Surgery, the True Minimally Invasive Spinal Surgery. Professor Dharmendra's lecture will mark the second time this prestigious lecture by a neurosurgeon in the University of Malaya and the fourth of its kind among Fraternity of Neurosurgeons in Malaysia since the inauguration of formal services in 1963. Without further ado, I would like to call upon Professor Adiba to chair the proceedings and introduce Professor Dharmendra. Prof. Adiba.
Assalamualaikum, good afternoon everyone. It's a mark of this faculty's need to multitask that we have a neurosurgeon as an MC for the proceedings. Ladies and gentlemen, distinguished guests, and Professor Dharmendra, I think many of you who have come to this Syarahan Perdana will know and hear that I often am thankful at the number of talented people that we have in our faculty, especially one that is homegrown, and we have a number of them, like Dharmendra, who started off as a medical student and did his master's in surgery here and choose to stay on despite the lures of private practice that many often we can't compete with. Yes, it deserves a big clap, especially to all of you, who, the rest of you also who've chosen to stay here. In fact, our chairman of the board, Tunku Azman, has been heard to say on a number of times that the Faculty of Medicine and PPUM are one of the country's best kept secrets, because we actually don't really trumpet the kinds of talent that we have amongst us. And when I read you Dharmendra's achievements, I think you will agree with me, and certainly after you've listened to his presentation this afternoon, I'm sure you'll agree with me even more. So apart from graduating from this university and completing his master's in surgery, Dharmendra went on to complete his FRCS Edinburgh in August 2001, and not enough with just one FRCS. He went for the Edinburgh and the Irish FRCS in September 2001, or is that the one and same thing? Two different things, yeah, so a glutton for punishment. He began his neurosurgical training in the Division of Neurosurgery at UMMC, and in the same year went on to do further training in Cambridge, where he worked as a registrar and trained in the field of neurosurgery, and then went on to pass the intercollegiate exam in United Kingdom and obtain his FRCS in neurosurgery. His passion has been in the field on the subspecialty of complex spinal surgery and also in pediatric neurosurgery. You all have his long long list of accomplishments, so I won't bore you with it, but I do know that Dharmendra and his team has developed, a formidable reputation in this country for their work in spinal surgery. For those of you who are approaching sort of the geriatric age, you will appreciate, as I do, the importance of good back care and the importance of avoiding back pain, which can be a huge contributor of morbidity, if not mortality, amongst older people. So we look forward to hearing from Dharmendra new techniques in minimally invasive neurosurgery that can improve patients' quality of life in the future.
Thank you, Prof. Dato Adipa Kamaruzaban, the Dean of Medical Faculty, for taking time to chair this event today, and also with a kind introduction, of course. Appreciation also to my colleague, Professor Dato Harichandran, the Master of Ceremony for the evening. A warm welcome to all the esteemed professors, distinguished guests, family and friends who are here in the hall, as well as those who are viewing this lecture online. Indeed, it's a great honor for me and privilege to speak to you today. I will take about an hour to describe not a surgical technique, not a notion, is not an innovation, but a notion, a philosophy of conservative spine surgery. What I have noticed in my practice of seeing new patients, as well as patients who come and seek second opinion, as well as attending meetings over the past 12 years, there appears to be a trend towards instrumentation of the spine for degenerative spinal disease. Because of my training as a neurosurgeon, I have a different perspective of these cases of degenerative spinal disease, a more gentler approach with lesser invasion of the spinal structures while still tackling the problem at hand. So today, after 12 years of practicing the philosophy, I'm going to share it with you. Some disclaimers, online and all that. The components of the lecture are such. Okay, some basic sciences before we dwell into the details of it. The spinal column is kept together by discs, joints, ligaments, and muscles, as you can see in the picture. I mean, these form a very important element of the entire spinal column. And each of these, if injured, can cause pain. Very important to understand that, because many times we just look at the bone, but any one of these can cause pain. Now, in the center of all this sits a delicate structure. Okay, it's called the spinal cord, and of course the nerves that come out of the spinal cord. The spinal column is made up of multiple vertebrae stacked up one on top of the other. The key surgical points to note is the vertebral structure changes from the top to the bottom in terms of the shape and the size. The cervical spine is the most mobile and hence prone to wear and tear issues, as you age. However, the thoracic vertebra, interestingly, is splintered by the ribs, and hence there's lesser wear and tear because you don't move it as much. The lumbar vertebra has a bigger base, as you can see from the picture over there. Yeah, it's got a bigger base over here, right? And that base is to bear the load when you stand and you sit and so on. So, and it's also a pretty mobile part of the vertebra because when you bend and so on, so it's also predisposed to wear and tear. So it's good to understand a bit of the anatomy to know why the cervical and lumbar really, usually is where the problem lies. And again, the brain sits in the skull, delicate structure also but in the skull, but the skull doesn't bend. And you've got an equally delicate structure in your spine and you can do gymnastics. So the uniqueness of the spine is it allows the person to bend the body while not kinking the delicate structure called the spinal cord within it, which transmit impulses to your entire body, your limbs. Now, in my books, there's only 2 indications to place the knife on the skin. Okay? Any other indication, I'll question it. It's questionable, right? Nerve compression, very simple, really. You saw the anatomy earlier. So, the nerves sit inside here, right? You can see from this picture eloquently showing everything being compressed. you do an operation to free the nerve. You can free the spine from any direction, but typically it's done at the back because that's where the bone is thinnest, and in the front it's pretty big, but in the neck you can do it from the front as well. So first the nerves are squeezed. As neurosurgeons, we look at the nerve first. Now the nerve is relaxed, as you can see. And the second indication for surgery would be spinal instability, right? I mean, you got a twig here, the twig is broken, somebody's put some rubber to hold it together, right? In essence, that's exactly what it is, right? You get a fracture, the fracture can be because of trauma, it can be pathological because of osteoporosis, can be because of tumor. You realign it, get the canal back to normal, and put some screws to hold it together until it heals. Now, at our facility, we offer a full array of techniques to sort out the job, right? We've got this microscope, endoscope, image-guided surgery, and so on. Now, our theatre facility, we are keeping up with times. Our theatre facility is keeping up with times. We have the state-of-the-art intraoperative CT scan and MRI scanners. And remember, these are just adjuncts to surgery, And now let me go back in time a little bit, you've seen the state-of-the-art. Let me go back in time a little bit. I'm fortunate to have a blend of creme de la creme teachers, throughout my career as a doctor, right? Many of them are right here today. However, in the interest of time, I'm only going to speak about a few of them. The late Dr. Ranjit Matthew Oman, right? Some of you might know him, my colleagues from Sabah. In my formative years, I had an opportunity to see a master at work, right? Skillful in theatre, very good outcomes. If there was a complication, he was there to sort it out, and liked and trusted by staff and patients alike. It was a center that was churning out surgeons via the FRCS method, like left, right, and center. I mean, there were so many of them coming out of that unit. I would like to share one particular experience that I had with him. There was once I was a house officer, a junior guy trying to show off a bit, There was a local minister, his mother was admitted with right lower quadrant pain. This patient was admitted and reviewed and it was decided that let's wait and watch. That strategy was employed to manage this patient and to see, how the clinical picture evolves. 2 days later, the family was a little anxious. Because, house officer is always in the ward, right? So when the family sees you, they'll ask you, what the heck is happening? You're not doing anything. So when he came for the next morning rounds, I told him that so-and-so's mother is here, the minister and all that. They're wondering, why haven't we done anything yet? Yeah, and he was walking and he stopped. Then he turned around and looked at me and said, I would have done the same thing for my mother. And she recovered and left the hospital without an operation. That thing stuck in my mind forever because the practice of medicine really is a socialist act. You got to treat everybody the same. It doesn't mean somebody is special because of certain things. So everybody needs to be treated the same. Now, Dr. Jairam Menon, he was something else. Very witty, full of sarcasm. In all that, he had this razor-sharp clinical acumen. I learned a lot about the application of knowledge of medicine with him. There was this grand rounds that used to happen every Thursdays. It starts at 2 o'clock and finishes at 9 o'clock. So, I used to cherish it because it was my weekly crash course to know how a proper clinical diagnosis from history and physical examination with some basic investigations were made. Solving a lot of the ward issues in that particular hour, right? All the ward problems would be sorted. Sorry, no pin. So there was once I was presenting my 18th case. We had 3 house officers. We had, I think, about 60, 70 patients, And the ward round goes so fast that you have to memorize the stories. And if you had to read the notes, you'll never finish the rounds, I think. So you had to remember the story. There's no time to look at the notes. So when I came to this 18th patient, I said, it was my turn to present. I said, 38-year-old gentleman from Ranau presented with fever for 2 weeks and platelet count of 60. Then I stopped. The reason I stopped is because I couldn't remember what to say next because I'd forgotten everything. Then he looked at me and said, where did you learn your history taking from? TV3? And then my MOs around me were doing exactly this, chuckling away, because the sarcasm wasn't on them. So they're just laughing. I just hope TV3 has improved. Now, I know it's not the Grammys and all, but I must record my sincere appreciation to my boss, mentor, and now my colleague, Professor Vigneswaran. I mean, he was instrumental in getting me going in neurosurgery, and he has allowed us to grow in our niche areas. Very supportive and always there if you needed a hand. He has many ideas. I don't think anybody can dispute that. No? Anybody wants to dispute that about his ideas and all? One of his ideas were we needed a subspecialized neurosurgical unit. I must commend him by doing just that. Not only has it made the unit grow with no civil wars, it has also made our unit relevant not only in the Klang Valley, but Malaysia at large. You know, in a way, I would not be able to speak on spine surgery in this manner if we were doing all areas of neurosurgery and preparing ourselves for general practice, like what Prof. Adiba said. Now, Mr. Rodney Lang was my mentor in spine surgery, I must say. While I was in Cambridge, fantastic teacher. He expounds a more clinical approach to the spine. The decisions are made based on symptoms and signs. I think that's very important, symptoms and signs. You know, he taught me the fundamentals of spine surgery. He had a rather gentler approach to degenerative spinal conditions using less instrumentation. And I must say, it's his teachings that gave me the confidence to manage spine in a lesser invasive fashion. Now, before we move to the next bit, now let me take you through some of my personal data on the subject matter over the past 12 years. In the past 12 years, 40% of my work was on spine, 40%. You know, out of the 2,000 odd cases, 40% was on spine. And as Prof. Adiba alluded to, I also do pediatric neurosurgery, and 35% of my work is on pediatric neurosurgery, with the remaining being bread and butter cases. Out of that 40% of spine work, half of it was on degenerative spinal disease. And what is degenerative spinal disease? Okay, degenerative spinal disease is a wear and tear condition of the spine which occurs with age. In a way, it's not a pathology, but an aging process. This philosophy of conservative spine surgery is most applicable in degenerative spinal disease. So I mean, this is some of the data we have, my personal data. A more detailed analysis of the degenerative spinal disease in terms of location and indications are seen over here. As you can see, right, disc prolapses and degenerative canal narrowing making like the most common pathology in spine that we have to deal with. Cervical and lumbar being the common locations by virtue of the mobility compared to the thoracic spine. We had dealt with about 229 cervical degenerative cases, with the bulk of the cases having cervical microdiscectomy. In the early days, we were doing fusion surgeries more often, meaning you take off the disc and you put a bit of bone graft there, and a few years later, two bones together. However, as you can see from the graph there, our fusion rates are quite high, also 57. But this is data from 2008, long time ago. However, right, with time, our preferred choice after microdiscectomy has been disc replacement unless contraindicated. And we have done it for patients who are like even 80 years old. Right? So the clinical evidence has shown rather unequivocally that disc replacement surgery has a better biomechanical physiology to itself and reduces adjacent segment disease significantly. We offer an array of other surgical treatments as well for cervical degenerative conditions. We regard the thoracolumbar spine, with regard to thoracolumbar spine, these are the figures. I mean, we don't have much fusion surgery, as you can see from the lumbar corner there on the right-hand side, and we do mainly motion-preserving surgery. A short break before we move to the next concept. Now, against the backdrop of the basic sciences that we spoke about, the theatre facility, technology available at our center, and the kind of work that has been done in our facility over the past 12 years, we're going to plunge into the core of this lecture, the concepts and the bases that give credence to this philosophy of conservative spine surgery. So kindly fasten your seatbelts. Now, I'm actually not talking about minimally invasive spine surgery, what Prof said. Don't mistake this philosophy that we're going to talk about with MISS. In fact, MISS is just a term to describe spine operations with minimal muscle dissection. That's probably the word, minimal muscle dissection. Many a times, the other key features of the operation is the same. Whereas what I'm expounding is a way to look at the management of degenerative spinal disease in a more gentler fashion, a more organic one if you may, minimizing the need to instrument the spine unnecessarily. Now the first point to make is the natural history. Now, does a structure that looks abnormal or malaligned really a problem? Does something need to be done for every imperfection that we see either clinically or radiologically? Some interesting questions. I mean, look at this. The Leaning Tower of Pisa, right, began to lean during the construction in the 12th century, and is still standing with a tilt of 3.97 degrees. I mean, that's the last they calculated, it was 5 and then now it's 3.9. They did some rectification, I think, in the 90s. So now it's 3.9, the tilt. And almost 800 years ago, I mean, this building hasn't collapsed, 800 years ago. Now, biology is not physics or mechanics. We got to accept that variation is a norm. The variation can be, small like this or large, as exemplified by the curve over there. No two of us are absolutely alike. Now, in degenerative spinal disease, 2 persons can have scans showing that the nerve is pinched, but only one may have symptoms. Now, that's an interesting fact, and that's true. That's what makes the practice of spine challenging. You may have to treat the patient and not the scan. You got to practice clinical medicine and make investigations only as an adjunct. Is it possible to predict how a particular degeneration will look like in 5-10 years? The answer is no. Therefore, preempting a treatment based on these assumptions are flawed. Now, just look at the tree over there with the roots and all that. Are you worried about the drain? Do you really need to cut the tree down? Or can you just prune it to reduce the proliferation of the roots? Or do you just wait and watch until you see a problem? But will that be too late? Bearing in mind, the tree has been there for 15 years. Will the drain rip apart suddenly on the 17th year? These are the similar sorts of conundrum in the decision-making of a case of degenerative spinal disease. The treatment would depend on your belief and philosophy rather than the real hard facts. Why disturb something which is in a steady symbiotic state with the ecosystem unless you can see a tangible problem, not a nebulous one? Hence, it's key to have a balance, not to underdo something or overdo anything. You're not seeing anything on this slide. Sometimes this may just be the right thing to do. Nothing. And also, sometimes you just This treatment is very often underrated. Sometimes even by the patients, I must say. They think they came and saw a neurologist. Nothing is black and white in the field of medicine, and is no different in the management of degenerative spinal disease. The ancient Chinese philosophy of yin and yang says the natural world is an interplay of both these forces. Hence, there are many gray areas in the practice of medicine, Only a shady spinal surgeon will see things in black and white. Now, things happen, brother. It happened in 2014 and again in 2020. Things meaning some unexpected outcomes and complications. Even though rare, but it can happen. So, again, in my books, right, you got to ensure the indication for surgery is pristine, with almost no other alternative. Honestly, in the current state of practice, the risk of dire complications, such as paralysis, is very low. It's in the range of 1 to 2%, and other minor complications such as infections, spinal fluid leaking, in the range of 5%, the most 10%, depending on the case. If the indication for surgery is clear, then it's worth taking that risk, Now, science bit is on your left-hand side and the artistic on your right-hand side. And somewhere in between, there's a transformation from science to art, right? So watching this video, right, you cannot dispute that surgery is a handicraft. Having spent 5 years doing MBBS, another 4 years doing masters in surgery, and another 6 years doing neurosurgery, right? Learning all the relevant sciences. But ultimately, the reality is that the practice of medicine as a whole and the management of degenerative spinal disease specifically is really an art form. Sometimes I feel the operation is the easy part. The decisions that lead up to surgery might be difficult, particularly in degenerative spinal disease. Now, what is this art of decision making called? It's called clinical judgment. It's a decision to strategize your treatment. Now, do you really need detailed measurements to decide on treatment? Most probably not. But you need all this for academia, writing papers to prove a point, to make surveillance of cases and so on. You need all this. But not so much in your routine clinical practice. So what encompasses clinical judgment? It's actually a decision made by amalgamating many factors, never in isolation. You can see the components over here, the patient factor, investigation, and surgeon. Let's look at the patient factor, right? Clearly, this is probably one of the important features, okay? You look at what the symptoms and signs are in the first place. And then you look at the background medical illness. If the patient is having bad medical illness, not fit for anesthetic, you're not going to do the operation even if you had symptoms and signs. And then we look at fitness, functional state of the patient, the quality of life, patient's wishes, of course, equally important. You can't just, anesthetize somebody and operate without his consent. And then investigations, what they look like, how bad. And in regards to surgeon, you're looking at, is there any other option you can accord the patient, the surgeon's experience, the training philosophy he had, and even clinical evidence. So I feel this is the hardest to learn. No simulation lab is going to teach you this. If there's anything experience does to a doctor, it's this. The gastroenterologist may call it gut feeling, but all other doctors call it clinical judgment. Okay, now a bit on evidence-based medicine, right? Now, evidence-based medicine has a sound footing, but the same cannot be said about evidence-based surgery. Some quarters, in fact, question whether it's a fallacy. Now, looking at the hierarchy over here, you can see the hierarchy over there. The meta-analysis provides one of the strongest evidence in surgery. And what is meta-analysis? It's actually a statistical analysis that combines the results of multiple scientific papers, okay? And the limitation stems from the variability of the input, output, and execution of the intervention. See, people collect papers done by everybody else, right? And when you do something, you got your own criteria, so when you put them all together to give substantial evidence, many of these variables make it a bit flawed a bit. So, but however, right, it's still the best evidence we have in terms of thinking of doing something. Now, I would say the surgeon can use the meta-analysis to appraise a particular technique and approach in the broad sense, gauge the usability, look at the outcomes, the safety profile as reported, But the onus is on the surgeon to evaluate the meta-analysis before critically, analyze it critically, not just read the conclusions, before practicing it. We are not looking for a perfect solution. We are looking for a right solution for that particular patient, okay? And this is what I call patient-centered management. Now, in conservative spine surgery, we are aiming to restore the function, the neural function, as well as the spinal mobility. We are not looking for reconstruction. If you overdo something, it might not be able to match the existing degeneration of other parts of the spine or the body. And it may give rise to secondary problems and sometimes adjacent segment disease, as it's called. Now, is there any role for prophylactic surgery in spine? For degenerative spinal disease I'm talking about. There's no proof that prophylactic spinal surgery is of any use in degenerative spinal disease. The spine is a dynamic structure. The degeneration goes on at a different pace, depending on various factors such as posture, ergonomics, occupation, the load, the genetics, and so on. To anticipate and extrapolate would not be a sound practice. And I have patients who are concerned that, is the age shutting down the doors for them to do anything in the future? When you talk about age, we have chronological age, which is calculated from the date you're born, and we have functional age, which is measured in terms of your fitness. Now, the functional age, rather than the chronological age, that helps decide if surgery is safe. As exemplified by this case, we had this 86-year-old man, he framed this up, it's 4 by 2 feet, framed it up and passed it to me and Prof. Vicky. And he also did a translation so that, he knows I don't speak Chinese, he translated it. But it's a lovely piece of work, It's such a lovely, I had goosebumps when I read it, I had goosebumps. Now, one key element in the management of degenerative spinal disease is core strengthening exercises. Okay? Again, very, very underrated, but very, very effective. Better than spine manipulation. Interesting paper, very interesting. This paper was published in 1994 in Spine Journal. And I think this paper sort of put things in perspective a little bit. You just read down here, the ratio of back surgery in selected countries as compared to the rates in the US for degenerative spinal disease. And you find that Scotland and England only do 1/5 of what is done in the US. Very little, you can see, look at that US right at the top there. And these countries down here a little bit. Now, what does this tell you? The management hinges on the viewpoint of the surgeon based on his training and inclination. Is one person doing too much or the other doing too little? That's really the question. Sometimes I really wonder, what is really driving this shift? Is it the training that these people are having? Or is it the innovation in the clinical sciences? Or is it just market-driven usage? Now, the onus lies on the spinal surgeon to apply sensible clinical judgment in managing the degenerative spinal disease. I know, a lawyer kind of joke, right? Yeah. No, honestly, I have no issues with chiropractors. Believe me, I got no issues. Okay, fair enough, Paulo. I see your angle. I know it's a problem in this part of the world too. I'll go ahead, with some examples now. Now, this patient, had right upper limb pain with increased reflexes, and you do an MRI scan, you see a large disc here pinching the spinal cord. Okay. So he's got symptoms, he's got a disc. So, you do an X-ray, you see that the neck is moving quite well. So you do an operation called microdiscectomy, meaning you take off the disc completely, so you get a hole over there. And in the past, we used to put a piece of bone there to fuse the two bones together, but now we've got a device known as a disc replacement, and this actually maintains mobility. So I would say this is a more physiological operation, even though you're putting an implant, but you're tackling two things. You're sorting out the nerve, and you're maintaining stability of the spine. Okay, so this is one example of what I'm professing now. And this is another interesting case, a 46-year-old man only, presented with some symptoms, of in upper limbs and lower limbs. And he had anterior spinal fusion 6 years ago. So he had slipped disc 6 years ago. Somebody saw him, took out the disc and all, put a piece of bone there and fused it. Beautiful operation, really. Can't fault it. The fusion looks wonderful. But what is the effect of this? When he saw me, I knew where the problem lies straight away. He had a slip disc just below where the fusion is. And why is that? Because this whole thing is not moving. It pivots on this particular disc space, and the disc has come out and pinched the cord. Look at that. The cord is squeezed to the corner there. Let me get my pointer. Okay. Cord here, disc there. Okay. So this again, another case of slip disc, quite straightforward. And similar philosophy is applied. Took out the disc and put this. Now, if I'd fused that segment as well, we are really in trouble. Then maybe I should go to private practice, but he'll still look for me. So then I won't know what to do. So that's why I did this. But by doing this, you will prevent adjacent segment disease in the future. So this is a good way to deal with it, particularly when the levels above are fused. Now, the third case, right? This is a teacher who came in with arm pain, difficulty teaching and all arm pain. This MRI here shows the cord to be very beautiful, no problem. But what's happening here? Right at the corner there, you get a disc pinching the nerve, hence the pain in the arm. Now, for a case like this, you can either go from the front and take off the disc completely. That's one way of doing it. But by doing that, right, you are subjecting her for an unnecessary disc replacement, even though disc replacement is a safe way of managing patients like this. But again, like I said, you don't want to do something that's not necessary. Now, her disc height, very nice. Only problem is in the far corner like that. Now, is there anything else you can offer to keep the spine as natural as possible? And the answer is yes. There's something known as foraminotomy, where you come from the back of the neck, you make a small hole at the back here. This picture, you don't take off the joint completely. You take off the joint completely, you have to fix the spine and stabilize it. Just take it out a little bit, free up the nerve there, and bingo, the pain is gone, And you look at the x-ray, small hole there, neck is stable, teacher can teach, So no problem there. So this again, I feel, again, is what I mean by conservative spine surgery. Even though disc replacement is something you can do as well, but she didn't need it. You do this and this will last for a long time. Now, this man from Penang, one of my colleagues' uncle, came during the MCO time somehow, difficult. I write a letter and all for him to come. So, he has got, as you can see from the scan, the cord is pinched. You should see a white line on both sides here. The cord is pinched. And I did this because I wanted to actually just tackle this because there is signal change in the cord over there. But I noticed that it's almost fused, this one. I can't break this thing open. So then I was thinking whether I should go ahead and do it at the back. Now for surgeons, right, who are here, neurosurgeons, they were spine surgeons, when you see the spine like this, okay, this is called lordotic, you can do something from the back as well because the cord will bow backwards. So that's one option. Now, many of them will actually do that and fix the neck. But what I did for him was, I did an operation, but I took off the bone at the back. This is called a laminectomy. The whole segment where you saw is all multiple areas of tight. But I didn't fix the neck. I didn't put a screw to fix the neck. I just did it. And why is that? That's because I preserved the facet joints, right? And by doing that, this 3 months down the line, of course, I'll keep an eye on him, for next couple of, years. But he's 76. He's not going to play rugby. So I think he actually, when he saw me in the 3rd month, right, he came walking back, right, and he could use his hand, dexterity all improve. So you got the job done. Now how do you prevent further deformity in the future? You can do neck strengthening exercises. People always look at solutions from the doctors, but if you balance your muscle from the front and the back, you should be able to keep everything at bay. Not everybody lives to 90 years old and change the country and all that. So it's like, you can get away with it. You do an operation, you can avert it without actually fixing the neck. Now, another case, right? A 63-year-old man with bilateral arm pain. He had pain both sides, very, very, very subjective sort of symptom, but bothering him and all. You see a neck like this. This is what I mean by a kyphotic neck. The neck bends forward instead of backwards. The backwards one earlier you saw, that's normal anatomy. So he's got a problem like this. Disc space is so narrowed, cord is so compressed in a few places, symptoms of pain in the arm. So you do a CT scan for him. Sorry, my gown keeps falling off. Okay. So you do a CT scan, you find that in the front here, right, you've got excessive bony growth. Okay, this is called osteophytes. Now, because of the osteophytes, you won't get much movement. And what stopped me from he saw many doctors, and many of them advised to do the operation from the back and fix the neck from the back. Now, why I didn't like that was because the spine was bent forward. So when you do that, your cord will never bounce backwards. You won't get that bowing effect. The cord won't bounce back. So I was thinking that, let me do some dynamic x-rays. I flexed his neck, and extended it. Very good motion, right? And he's got this kind of deformity. Even if I took the bone from the back, I won't really sort the problem. So I counseled him, back and forth on every option. Because, to be honest, there's no one way of doing it. Even if you've done the operation from the back, I don't think it's a mistake. But using, again, my conservative spine philosophy, right? This man is, how old is he? He's 63. Young man. So what I did was I took off the critical areas, jacked up the height. Can you see the height here and height here? Jacked it up. That freed up all the nerves that went to the side. And I also maintained motion for the patient. That the spine could still move, right? So this, again, is what I call as conservative spine surgery, where you endeavor to sort the neural problem and also give the mobility. By doing that, right, you also reduce the risk of wear and tear. Now, this is symptomatic lumbar disc prolapse, sciatica. This is probably one of the most common things you see. So, typically when the patient comes to see you, very excruciating pain going down the foot, and the philosophy remains the same. You must manage medically for 6 weeks, right? Unless there's cauda equina syndrome, meaning there's bladder, bowel problems, cannot pass urine, or weakness, dire weakness and all. And once it fails, between 6 to 8 weeks, if it fails, then surgical options are to be considered. And typically, right, 80% would improve just with conservative management, not doing anything. And 20% would need surgery called lumbar microdiscectomy, where the spine is entered from the back, the nerve pushed away, that side, and then we pluck out the disc that is there. Okay? Simple surgery, patient discharged next day, no need to put any implants. Simple operation, right? But you don't have to do it straight away because they do get better. 80% get better, So hence, again, this is my philosophy of conservative spine surgery. You got to exhaust all options. Again, like I said, unless there's weakness or the patient can't pass urine, that's an emergency you have to do. There was a joke that the spinal surgeons, I overheard this in a spinal surgeon meeting. I went. They said, let's do the operation quickly before the patient gets better. Okay, now this one, I know, paradox, right? Yeah. 70 years old with lumbar canal surgery. These patients actually present with like tightness of the muscles in the thigh, the calf, So, classic symptom, classic scan, right? There's no questions about it. This patient needs operation because their quality of life will improve, And we are talking about a good 90% improvement. Joints, the joints that hold the spine together. You're free to take off the lamina, free the nerve, undercut, we call it. Go underneath and cut it, but don't take the joints out. Now, by doing that, this patient 1 year later, he had an inherent slip of a grade 1. They call it grade 1 spondylolisthesis. He had it. Now, many will use this as a reason to do spinal fusion surgery. But again, thanks to my training, my mentors and all that, I feel if your dynamic X-ray doesn't show the spine to be moving too much, patient's age, patient's level of activity, and so on, it's it's all right just to take off the bone at the back, free the nerves. I mean, he did very well, this man preserved the thing. And this 1 year down the line, I mean, the grade 1 slip has not got worse because we preserved the facet joints. Now, I always tell the patients, you've got a chance of this taking place. And I would quote that figures about 10% of further slip of the bone whenever you see this. I mean, you've got to tell them that because that risk is there and it's real. Now, if that happens, then of course, you've got to consider doing the surgery. Now, I mean, fusion surgery, I call it, putting screws and all. But that risk is only 10%. I mean, why do something upfront when you've got no signs to do it in the first place? Now, I want to extrapolate. I mean, my concept of conservative spine surgery works very well with degenerative spinal disease. Now, can I extrapolate this philosophy to other areas? You know, you saw earlier there's tumors and all that we do and trauma as well. Now, this patient is 27 years old. Neck pain, arm pain, slight weakness. Somebody did an MRI. They found a large tumor here, right, from the top to the bottom. So I went ahead to take off the tumor, right? So that one no need to go into details. But what I want to share with you is, you need a window to get into the spine, right? So we take off the bone at the back here called the lamina. You take it off, do the operation, close the lining, and put the lamina back with plates and screws. That's exactly what I did over here, right, with plate and screws. So again, this comes under the umbrella of conservative spine surgery, where you did not fuse the spine with screws and all because you did the operation. And secondly, you put the bone back so that the muscles don't get stuck onto the dura. And for any reason the tumor recurs, you have to go back again. And for a tumor case, right, you don't want to put screws because, I mean, sometimes you have to, but most times I work hard to not put it. And the reason being, when you do MRI with screws there, even though they're titanium, you can do the MRI, but you get a lot of artifacts. You get a lot of like funny artifacts. You can't interpret what you're seeing. So again, this is applying that philosophy. Another interesting case, durian seller from Rao. I haven't got my durians yet. Tumor here. And when I looked at the MRI, I thought the joint is gone, finish. So I have to fix the spine when I do the operation because as soon as one of the joints go, right, we are looking at a fusion operation already. So me and my conservative approach, right, you know now, right? So I did a CT scan. So when I did the CT scan, what I see is the pedicle is thinned out, but it's still there, thinned out. And the joints, right, they are touching each other still. So it's not completely gone, right? So because of that, and also being the thoracic, right, you've got your ribs to splint everything. So I went ahead to do this operation from the back. I took off the lamina. I maintained this joint. I took out half of this joint here, not fully, just half of it, in order for me to get access as far out as I can. You can see here the beautiful aorta there, just adjacent to the tumor, So I went there, and this is the post-op scan. You see all tumor removed, no implants, a little bit left over there. Even that also I managed to downsize a little bit from that approach. Now this patient's tumor is a schwannoma. Schwannoma is a benign tumor. So it's about, I think, coming to a year now, I think. My cardiothoracic surgeon is keeping an eye on this also because they can easily pluck this out by doing a scope if they wanted to. But because it's a schwannoma, we're just watching it. And he's doing well, but again, like I said, I haven't got my durians lah. Now, this lady here, unfortunate, 75 years old, fell backwards, just fell backwards in the bathroom, and she dislocated her spine badly. And this happened a day before Raya, before Raya. She went to another hospital. They gave her, unfortunately, at the same time, she had an acute myocardial infarction. So couldn't do the operation for 2 weeks, put her on LOS, waited, then reduced it and fixed it. Now, what I want to show in this case is, right, the MRI shows she got no slip disc, so you don't have to go from the front. You can actually just make a case and go in the front and do it, but you don't have to. You reduce it, fix at the back, and you don't have to do extensive fixation. Why? 75 years old. Thin lady, 75 years old. You bring it together, put a lot of bone graft there, and you're done. And she's doing very well. I saw her walking the other day and all. So you can apply that to this as well. Not overdo the constructs. Certain areas you can omit. Again, all that need to go on clinical judgment, which all the features I spoke to about earlier. Okay, I hope, Paolo, you're satisfied with the cases I showed, the examples you wanted to see, right? I've shown you everything. Or do you need more cases? By the way, none of the above cases are made up. They're all true. I can give you the registration number if you want. Just quickly, to touch on some treatments that we should resist, okay? Now, this guy, this is the original scan. This is his original X-ray. He's 65 years old. He went in with back pain and spinal claudication. So the doctor did this for him, I must say, the work is beautiful, right? Very beautiful. But the patient is still symptomatic. So when he saw the doctor said, I don't know why, but your scans are very nice. To be honest, right, you got to always endeavor to find the source of the problem first. And I think here, we are not looking at an entire scan, but just this picture here, right, for a 65-year-old man, I feel this is too much. I haven't seen everything yet, but I can tell you, you've seen some of the earlier scans. This doesn't look bad to me. The lordosis is still pretty good. The curve of the spine very good. So sometimes, right, this is not the solution. Perhaps now it's a start of a bigger problem in the future. Aggressive fixation, immobilizing large segments of the spine. You can have consequence from this, as you've seen from the case above. Again, this is a no-go for me. Now, there's so many things in the market these days, as you can see all the thing all over there. Now, premature initiation of treatment prior to giving time for the body to self-heal itself places the patient in an unnecessary risk, right, of a particular intervention. I'm yet to be convinced myself of the utility of these modalities in spine practice due to the lack of adequate biological science and robust literature support for it to be used as a standard clinical practice. Even though the laboratory physical studies and some of the brief case series published have shown positive results, but there are no proven consistencies. There's no decent data that has surfaced in a sound, reputable clinical journal. A lot of publications are in the preclinical and basic sciences journals. There is potential in some of these treatments. I'm not denying it in the future. There is definitely potential for some of this. But in the current time, right, anyone embarking on any one of these has to do it cautiously, with proper counseling of the patient and consenting them, because I cannot see any one of these being standard. People have approached me with this as well, but I really can't see the science of it at all. The stem cell is something that is growing, but again, the evidence as such is not enough to inject it into a disc space. Now, this technique, I put it in pink there because I won't say no to this one. That's why I put it pink. Everything has a meaning in the slide. This technique is actually gaining traction. But there's a steep learning curve, and there's a highly selective indication to use it. Need a level of competency to obtain the desirable results. Just because you do something right, that doesn't mean you're good, You got to do it right. So you got to have the expertise to do it. So if you don't have the expertise, doing it in the standard fashion may all be better. Do you understand? People get this idea that, you're doing endoscopics, fine, let's do. But are you going to do a good job, So when it comes to this, you need to watch the space, because I think there is potential for this and it might get better. Now, this cafeteria, right, you've seen it in our hospital premises. I'm sure the same is demanded of spine surgery too. You demand the same thing. But the irony being, right, lesser is more in spine surgery. Okay. Now, before I wrap up the evening, I wish to acknowledge a few people I truly hold dear. My late father and my mother, for all the sacrifices that they made, that has culminated in me having this opportunity today. And my better half, who has always been very encouraging and understanding, despite my extremely lopsided work-life balance. Okay, my little ones up there. I hope one of them sleeping already. I hope you now understand why I keep repeatedly breaking the promises to take you guys to the park at 6 p.m. Now, to conclude, we need to see the management of degenerative spinal disease through a more conservative lens. The philosophy of tackling the spinal problem with maintaining the mobility of spine and restoring the neural function to the optimum is the true minimally invasive spine surgery. If this is achieved with a slightly longer scar, so be it. Safer surgery and functional well-being in the short as well as the long term is more critical than any other parameter, example, shorter hospital stay, cosmetic scar, and all that. Each case has to be assessed on its own merits with the right clinical judgment applied. My references. Now, the conservative spine surgery philosophy is the way to go, and it's definitely here to stay. On that note, ladies and gentlemen, I thank you.
Thank you very much, Prof. Dharmendra, for a very insightful, candid, and a thought-provoking lecture. Thank you very much. Now, they say the proof of the pudding is in the eating. So I was looking at the audience, and I was most pleasantly surprised to report that throughout your lecture, there was no prodigious chatting or parallel lectures going on in the audience. So thank you very much. I would like to call upon our Dean, Yang Berbahagia, Professor Dato Dr. Adiba Kamarul Zaman, to address and close the proceedings. Prof. Adiba.
Thank you very much, Hari, and congratulations, Dharmendra. Now you understand why he's still here with us, because even if he went out into private practice, he wouldn't be making any money, Dharmendra. You would still be seeing patients and charging them 100 ringgit and not the thousands that you would be doing from, I wouldn't say unnecessary spinal surgery, but perhaps, unnecessary spinal surgery, as you tried to educate us this afternoon. Now, I took a photo of the slide that you showed of Dr. Jayaram. Are you in the audience by any chance? No? He's watching it online. So Jayaram, who's a very good friend and colleague of mine, you must be very, very proud for training a neurosurgeon who's really, really a physician. Yeah? You after today's lecture, you'll be putting a few orthopedic surgeons out of work. Any orthopedic surgeons in the audience? No, I'm sure they won't mind. Yeah. So I started off by introducing today's lecture by saying that I'm very proud of the talent that we have within, and rattled off Dharmendra's surgical training in some of the most illustrious institutions around the world, including Edinburgh and Cambridge, etc., and the string of letters that he has to confirm his competency as a neurosurgeon. But I think after listening to him today, it's not so much his cutting skills that I hope one day I will never have to call upon you. I'm very glad to see that you have validated my getting up at 6:30 every morning to do those back exercises with yoga. So I think what really makes I hope all of those of you from UM today extremely proud is not just your surgical skills, but really what we hope to instill in all our students and our trainees and our junior and not so junior colleagues, that ultimately, it's the patient that really matters. And yes, of course, we all practice evidence-based medicine, evidence-based surgery, but in the end, a very good history and listening to your patient and their wants and needs and their, as you repeatedly pointed out, their age and what you can expect from them and their quality of life is what matters. And for that kind of medical practice that you are obviously practicing, it takes someone who cares, and ultimately that is what we hope that this institution is going to be is famous for, not going to be famous, is famous for. So with that, congratulations and thank you, and towards more minimally and conservative spine surgery and other kinds of surgery as well. So thank you.
Right. Thank you very much, Prof. Adiba, for chairing Prof. Dharmendra's inaugural lecture. I would also like to take this opportunity to thank the management of the Faculty of Medicine, the International Corporate Relations Office, citizens of University Malaya, as well as all the distinguished ladies and gentlemen who have made the effort to attend this lecture today. Thank you very much. So with this, we have reached the end of the lecture. On behalf of University Malaya, I would like to impress upon you all the last bits. Now, in line with our adherence to social distancing, kindly leave the hall in an orderly manner as requested. I will tell you all how in a minute. For those who can entice Prof. Dharmendra to a photo shoot, please proceed with this outside the lecture hall. Note that a photo booth has actually been set up for this purpose. We are unable, I apologize, in true fashion to proceed with the usual high tea that follows these inaugural lecturers due to constraints from the COVID-19 pandemic. Yeah, not finances. This time it's the COVID. See, we have got the COVID to blame for it. However, takeaway bento boxes and tea have been prepared for all you ladies and gentlemen. Kindly help yourselves on the way out. Now for the exit from here, that row and that column, kindly exit through the gate A, or rather door A on my extreme right. This row and columns will exit from door B on my extreme left. After they have exited, the center row and columns, please leave in an orderly fashion. Don't want to go into technicalities of even rows go to A and odd rows go to B, but try and work out some system. All right, once again, thank you very much.